My name is Benjamin Moats, and I am the first-year HPB Surgery Fellow at Atrium Health. Today, I will be presenting robotic hepatectomy as a feasible, minimally invasive modality for experienced liver surgeons. These are my disclosures. Dr. John Martini is a paid consultant for Intuitive Surgical. Modern liver surgery has benefited greatly from advances in perioperative care and surgical technique, as well as a number of innovative technologies that have significantly reduced morbidity and mortality associated with these procedures. One of the major advances over the last 30 years has been the adoption and development of minimally invasive techniques, beginning in the 1990s with laparoscopy. Since that time, numerous studies have shown improvements in outcomes with decreased operative morbidity, shorter hospital length of stay, and improved patient-reported outcomes, including postoperative pain and quality of life. As utilization of laparoscopy increased, the first World Consensus Conference was convened in Louisville, Kentucky in 2008, leading to the publication of the Louisville Statement in 2009. This established definitions for laparoscopic hepatectomy and specified indications for considering laparoscopic resection, including small peripheral lesions or those in the left lateral sector. These recommendations were based on the understanding that laparoscopic liver resection is technically demanding, requiring experience with both advanced liver surgery and advanced laparoscopy. Since the publication of the Louisville Statement, minimally invasive liver surgery has increased exponentially and has been further validated following the second International Consensus Conference on laparoscopic liver surgery held in Moriyako, Japan in 2014. Despite these concerted efforts to expand the utilization of minimally invasive liver surgery, and despite exponential increases in the use of MIS techniques, in a 2015 review of the NISQIP database in the United States, only 5.1% of liver resections performed between 2010 and 2012 were performed minimally invasively. The use of the surgical robot to perform MIS hepatectomy was first reported in 2003 for a small partial resection, but indications and utilization have expanded dramatically since that time, leading to the publication of the International Consensus Statement on Robotic Hepatectomy in 2018. Robotic surgery has been proposed as a modality to decrease the learning curve for liver surgeons who have limited experience with minimally invasive approaches. While this has been clearly demonstrated with other types of minimally invasive procedures, there are few studies evaluating the learning curve for robotic hepatectomy. Our robotic experience at Carolinas Medical Center, the flagship tertiary care hospital within the Atrium Health System, with a high volume HPB program, began in 2012, with all procedures prospectively maintained in our comprehensive HPB REDCap data repository. In order to characterize our learning curve and outcomes over time, this database was retrospectively queried for all robotic hepatectomies performed from September 1st, 2012 through September 30th, 2020. All robotic hepatectomies were performed by 2 robotic surgeons, each with extensive HPB experience, but with different levels of robotic experience. In order to evaluate trends and outcomes related to experience, patients were divided into 5 equally sized epochs based on date of surgery, with 53 patients per epoch. In total, 265 robotic hepatectomies were performed over the study period. Demographic breakdown is shown in the chart. In general, there was a female predominance and most patients were white. The majority of patients were American Society of Anesthesiology Class 3, and 19 patients were ASA Class 4. 90 major hepatectomies of at least 3 contiguous segments were performed over the study period. There were 54 right hepatic lobectomies and 33 left lobectomies. Over the study period, the number of robotic hepatectomies performed per year has increased steadily over time. However, within each epoch of 53 patients, there has been no change in the proportion of major hepatectomies performed. This shows that even complex liver resections were performed early in the learning curve for robotic hepatectomy. The exception to both of these trends was the year 2020, For unclear reasons, although we hypothesize this may be related to the COVID-19 pandemic and represents an area of further study for us. Although major resections were incorporated into our robotic practice early on, operative outcomes have remained remarkably stable over time. Our average estimated blood loss is 435 milliliters, with major resections losing an average of 555 milliliters and minor resections losing an average of 343 milliliters. Mean operating room time is 196 minutes, with major resections requiring an average of 243 minutes and minor resections taking 172 minutes. On ANOVA analysis, there is no difference between the different epochs in terms of either mean estimated blood loss or OR time. Similarly, postoperative outcomes did not change appreciably from the earliest days of our robotic liver program. Median hospital length of stay following robotic hepatectomies is 3 days, and there has been no change over the course of the 5 epochs. 54 patients, constituting 20.4% of cases, suffered complications. However, the majority were minor, and only 12 patients having at least a Clavien-Dindo grade 3 complication. As with other outcomes, there was no significant difference between the epochs. In conclusion, despite active measures to increase utilization of MIS approaches to hepatectomy, these techniques remain underutilized due to technical complexity. After the development of our robotic liver surgery program at Atrium Health, case volume increased steadily over time with favorable operative and postoperative outcomes, showing that the robotic approach is both safe and feasible. Additionally, independent of the complexity of resection, these outcomes remain stable over the 8-year study period. This suggests that for experienced liver surgeons, adoption of robotic techniques is associated with very little learning curve and presents an opportunity for HPB surgeons with limited laparoscopic skills to incorporate a minimally invasive approach into their practice. Thank you for your attention.